All right. Thank you, Floyd. Thank you for the invitation to you, Floyd, and to Dr. Lubbers and the rest of the committee. So I am a member of the Division of EMS here at University of Cincinnati. I just recently actually moved to Cincinnati from Chicago, where I was part of the medical director team for Chicago EMS. I chaired the state stroke advisory committee for their Department of Health as well. So I think about pre-hospital stroke care a lot. So let's go ahead and get in it. Just a couple of disclaimers here off the front, very minimal disclosures to report. And here's kind of our game plan. It really is to talk about really the basics of acute stroke, and then also really the implications for you as a pre-hospital care provider in that whole context. So hopefully, you know, stroke is bad. I don't have to tell you, but there's obviously morbidity, but also mortality. You see this on when you run on post-stroke patients. It can really be a devastating process. And even now, this is not a talk about COVID-19, but even in the context of COVID-19, it is a prothrombotic state. And so we're seeing increased amounts of ischemic stroke, but also hemorrhagic stroke as well, because there is some effect on the vasculature as well. We're seeing it in the younger population. This is out of New York City, where obviously they're being hit hard with COVID. They're seeing a lot of stroke in populations that we don't normally see it in. So good to be mindful in our area. Now I'm going to take if you would humor me and indulge me for just 2 minutes. I just want to talk very basic about the basics of stroke. There's a wide range of audience here. I just want to make sure that we're all talking the same language. It might be a good refresher if you're already pro at this, but ultimately, what is a stroke? It really is just a limitation in blood flow to any part of the brain that ultimately just leads to a sudden neurologic symptom. So we typically think about this as arm, leg, and face weakness, but really it could be anything: slurred speech, severe headache, isolated dizziness. These are all potential signs of stroke. And it really kind of comes down to what is the mechanism. So when you talk about ischemic stroke, that's a blockage in the blood flow in a blood vessel to a specific part of the brain. I kind of like this picture. This is a unfortunate tree with probably a fungal infection or something like that. You can see that a branch is dead. The rest of the brain is actually, or the rest of the tree in this situation is actually doing okay. The analogy is that the way that the blood flow in the brain is, it kind of comes up one branch to feed a specific part of the cerebral cortex there. The other parts might be fine if there's a focal isolated blockage. Now, that blockage is usually a blood clot. It usually comes in the context of atrial fibrillation. This is why folks who have atrial fibrillation are on blood thinners to reduce this risk. Theoretically, some stroke is caused by atherosclerosis, far less common as a cause of a large stroke than this mechanism is for STEMI, for example. But the symptoms really depend on what part of the brain is just not getting the blood flow. The blood vessels really do kind of emanate from that central circle of Willis and then feed specific parts of the brain. There is some collateral blood flow, but really it is dependent on kind of what part of the brain is fed by that blood vessel. The parts of the cerebral cortex are very specific in what parts of the body they control. So this is a homunculus picture. So part of the cerebral cortex is demonstrated here. And so if you look at kind of this blood vessel right here, that really does correspond to maybe the left arm, or I guess right arm in this picture. There are other parts of the brain, like the cerebellum that does your balance. There's a specific area in the frontal cortex here that does your speech. And so each part of the brain with each specific function has its own specific blood flow. So that's why the symptoms of stroke may not be the classic facial droop arm weakness. They might look like other things. It might be isolated vertigo. It may be a bad headache. And then here's addition. It may be hard for the patient to describe it. If they have part of their speech area that is affected by the stroke, they may not be able to tell you the signs that they're experiencing. They may be comatose or at least altered. That's ischemic stroke. The other type that we always think about in this context is hemorrhagic stroke as well. That's any kind of bleeding in a specific part of the brain. Now, when you have a ruptured blood vessel, the downstream brain cells are affected, and so those are not working well at all. There's also mass effect. For example, if you have bleeding kind of right here into, kind of the midbrain here, you're going to have mass effects as well. These are where risk factors like high blood pressure, high cholesterol can make that blood vessel more prone to rupture. They may have symptoms similar to ischemic stroke. For example, if you have a intracerebral hemorrhage this big, you're going to have some focal symptoms, but really this one is also going to be pressing on the rest of the brain and probably leading to a comatose state as well. Often these folks are nauseated. They may have very severe symptoms like fixed gaze deviation. Seizures are pretty common, and it may even rapidly progress to coma and respiratory compromise. Subarachnoid is another type of hemorrhagic stroke that is usually from an aneurysm that ruptures and kind of bleeds in that space around the brain as well. It can be focal, but usually the classical symptoms for this are severe headache, which means that their mental status might be normal. They're oftentimes quite uncomfortable. They're oftentimes nauseated, but not always. It may be small enough that we're getting a little bit of a warning sign. So even a mild headache that is sudden on onset, we always think about this. Ischemic stroke is far more common. We're going to focus mostly in this talk on ischemic stroke. Sometimes their symptoms are overlap. The treatments are vastly different, as you can imagine, for a bleeding stroke versus an ischemic stroke. A lot of what we're going to talk about today, like I said, is ischemic stroke. And in that context, the treatment goal is really to restore that blood flow. So there is a spot pathophysiologically right at the site of the blockage where the brain cells are starting to die. Ideally, there's a large area around that that is still getting a little bit of blood flow kind of hanging on from some of those collateral blood vessels that if we're able to reperfuse the area, we can hopefully save. And so that's kind of the treatment goal, at least conceptually. We do that most commonly through medications that lyse the clot. A common one is alteplase or TPA. Tenecteplase is another one that's gaining a little bit more traction recently as well. But the goal is to break up that clot and restore blood flow, with the overall clinical goal of improving stroke symptoms, ultimate disability for a number of people who are treated. And we focus on that positive effect on a certain number, a certain percentage, up to 30% who may benefit. Even though we treat a lot of people with acute stroke, many are not affected, either positively or negatively by the treatment. And we have to recognize that. Some are even harmed. Even more important in terms of the decision-making, who we give this medication to. A lot of kind of what we ask of you in terms of last known normal risk factors, are they on anticoagulation, is meant to, as best we can from a clinical perspective, reduce the risk of harm when we give this medication. You all know that in 2015, the landscape of acute stroke really changed, and that's with the improvement in really patient selection and also processes of who we do endovascular therapy on. We saw this dramatic improvement in folks who are treated with endovascular who have very specific syndromes, namely large vessel occlusion. So this is that same picture with the blood flow emanating out and supplying the parts of the brain. Endovascular therapy is really good for these large proximal vessels. Once you kind of start getting out here, it's just too technically challenging. The arteries are too small and you run increased risk. But if we can find a blood clot in this area right here up until probably that second branch of the middle cerebral artery, those are the patients that we're seeing the benefit when we do endovascular therapy. Ultimately though, it's not just about large vessels and where it's at, it's also about time. Really, when it comes to acute stroke, the benefit of treatment is time dependent, and I need to stress that. For every 15 minutes that treatment is improved, patients do a ton better. Mortality is increased, the chance of going home, independently ambulating, and side effects are decreased the sooner that the thrombolysis, the TPA medication, is given. Even with endovascular, we can do endovascular out even as long as 24 hours in some very select situations. But you can see even well within kind of the range that we usually recommend endovascular therapy, patients do better the sooner that they are offered that therapy. So patients who are kind of in this light blue have either no deficits or are very functionally independent. On this side, this is death and severe disability. And as you can see, as the time to treatment increases, the chance of death and severe disability is much increased. So remember, time dependency when it comes to stroke treatment. And a lot of that is dependent on this stroke chain of survival. It really is dependent on everything from the beginning, right when that stroke happens, all the way through an ICU admission at the hospital. We think about it in the context of both hospital base and pre-hospital. There's been a lot of work done on the hospital, and that's where kind of your stroke teams at the receiving hospitals have improved their processes, door to CT, these sort of things. We're interested more in the pre-hospital because this is such an important piece of this chain of survival. The chain is only as strong as its weakest link, and so as long as we can strengthen the entire chain, our patients are going to do better. This starts with laypersons detecting stroke, and this is where you see the messaging about FAST by American Heart Association and others, getting the word out about calling 911 as soon as they recognize symptoms. Dispatch is such a critically important. I don't know if we have any call takers watching this, but you are critically important in this whole chain of survival. You know that 911 dispatch call taking is challenging. You're there, the bud is in the ear, you'll hear the tone go off, and then you might have someone screaming in your ear. To try to sort through the information, let alone where the location is and all that, is really tough. And you got to do it within a minute or so. It is really tough, and we appreciate your work on the other end of the line. But I'll tell you, it is so critically important when stroke is recognized on the phone. Across the board, any system that has looked at this, dispatchers, call takers recognize probably about half the calls for stroke, and they're usually correct when they do, just from the information on the phone. Recognizing stroke cues the responding EMTs and paramedics, and ultimately does improve overall time to treatment. We actually looked at, back when I was in Chicago, we actually looked at the words that people used when they called 911 for stroke. We did a qualitative analysis on the audio recordings, and it turns out that when laypersons are calling, they are oftentimes using vague, non-specific symptoms. Oftentimes they are actually saying things like, oh, I think he's having a heart attack, whereas really that's a stroke. Far less frequently are folks actually describing focal neurological symptoms using the word stroke. But if we do kind of word count analysis, the instances where the dispatcher and the call taker recognize stroke, far more common if those more kind of classical descriptors are used, both either by the dispatcher or by the caller. And so we have this mismatch, probably an opportunity for improvement, but a mismatch between a layperson using vague language and really kind of an expectation to kind of hear more concrete signs and symptoms. So we think that there's probably an opportunity there as well, because it's such an important link in the chain. For many of you who are on-scene providers, this delivery link is where you come in. Super important, obviously. And a lot of things come into this. It's the stroke systems of care, it's pre-hospital stroke detection. So it's actually doing the screening and realizing that, well, then maybe this is an acute time-sensitive process like stroke going on. Pre-notification, and then we'll talk briefly about severe stroke screening as well. When EMTs and paramedics recognize stroke on scene, a lot of good things happen. Time is expedited for these patients. On-scene time is shorter when you show up and you're seeing a clear stroke. You're going to go to straight to a stroke center. You're letting the stroke center know. And this really does translate in more patients receiving treatment for their acute stroke. For those of you who were in practice 10, 15 years ago, and we didn't really have the maturity of stroke systems of care, you'd bring a stroke patient to a local hospital. Far fewer instances of patients were being treated. Well, after, this is Chicago's experience, but after kind of the stroke system of care with primary stroke centers, comprehensive came into play, almost doubled the number of patients were being treated, and it was sustained. This is important because the transfer time between hospitals, it takes a lot of time. This is, again, Chicago's experience, but it's about 2.5 hours if you need to do a transfer. And that might actually time someone out, especially from one of these endovascular treatment options. Even pre-notification does a lot of good. It can cut off as many as 20 minutes in this one study that looked at their pre-notification from EMS. An important development, which if you're practicing clinically right now, you of course know, which is the reflection of the endovascular treatment on what we do in the pre-hospital setting. And a lot of it is rooted in what different levels of stroke centers can do. Acute stroke ready hospitals, IV TPA or thrombolysis transfer. Primary stroke centers can do a lot of stuff, but not necessarily reliably the endovascular treatment for large vessel occlusion, definitive treatment for hemorrhagic stroke, or necessarily neurological ICU treatment. Thrombectomy capable stroke centers are becoming more popular. They're kind of right in between the primary and the comprehensive stroke centers. They can offer endovascular treatment, but they may not be able to offer some of the hemorrhagic treatments and may not have necessarily a dedicated neurological ICU. In order for us to kind of think about making that distinction, a lot of the large vessels, severe stroke screens have grown up. This is not a talk about that, but suffice to say, there are a lot out there. The basic goal is to simplify the NIH stroke scale, which we do in the emergency department side. And it really is just meant to be a screen. It is not meant to be diagnostic. And whenever you have a screen, it really strikes that balance between sensitivity and specificity. So if you have a screen that's very sensitive, the test will pick up stroke. The problem is you will have a lot of false positives as well. The flip side of that, if it's a very specific test, it means that that test is waiting to ding positive only if it's pretty sure that there's a stroke. The problem there is you're going to miss a number of strokes. And so it's this balance. We see that reflected in the test characteristics of the CStat, the LAMS, the RACE. There is this balance between sensitivity and specificity. None are perfect. None are perfect. There has to be some sort of system level accommodation for the gaps, whether it be over triage or under triage. There's also anatomical gaps. So a lot of these tests are really good at determining basically middle cerebral artery distribution, arm, face, leg. But remember, you have the balance center, you have the speech center that may not necessarily be encompassed by a purely motor screen. Additionally, if it's a ruptured aneurysm and there's a subarachnoid hemorrhage, if the presenting symptom is severe headache, that's not really captured in any of these. And that's really where your clinical judgment about something's just not right about this, I think we need to do the right thing by the patients is really so important. Sort of this conversation and discussion is kind of fed into the Mission Lifeline AHA recommendations for primary stroke center versus comprehensive stroke center that Dr. Hinckley mentioned earlier this morning, and thinking about where is the best transport location. The AHA and Mission Lifeline makes some guidance around kind of time from last known normal symptom onset versus time to the primary versus comprehensive for EMS systems to consider. But it's a really complex decision, and it's an important consideration when you're thinking about the test characteristics as well as kind of your own regional capabilities. Even more so in the era of COVID-19, this came out just 2 days ago, thinking about, well, should we even consider some of the considerations when it comes to COVID in that destination decision? These authors who are prominent in the field, thought leaders, consider, well, if we have to do an interfacility transport on the back end of that, that's a ton more PPE, a ton more exposure to EMS personnel. And so they're suggesting and thinking about, well, maybe we actually kind of think a little bit differently about kind of where we set that threshold for primary versus comprehensive. Like I said, hot off the press, not making any recommendations, but this is going to be an interesting conversation, I think, moving forward. So when it comes to severe stroke screening, again, we didn't go into all the weeds about it, but as a high level overview, recognize just a screen. Your clinical decision making is important. Nothing's going to be perfect. And so systems of care need to be accommodating either of over triage, so of non-strokes going to stroke centers, but then also there needs to be robust interfacility transport capabilities of bringing a patient who maybe didn't screen positive or just walked in, came by private vehicle to a primary stroke center and non-stroke stroke center need to be transferred. It really all comes down locally, though. You have to know the capabilities of your systems and the realities of what your agencies are. And these are really individual discussions based on your EMS system, I do believe. The last thing that we'll talk about is mobile stroke-units. This came up earlier. This is really kind of a glimpse forward. So what is a mobile stroke unit? Well, it is a specialized ambulance. It has everything an ALS ambulance needs or wants. It also has a CAT scanner. So the CAT scanner can tell us if there is something going on in the brain, like a bleed, like a tumor that would preclude the use of TPA. It has a telemedicine setup where a stroke neurologist can assess the patient in real time, just like they would in the emergency department at the primary stroke center or acute stroke ready stroke center. It has critical care trained paramedics. It has nurses, CT techs, all set up and actually stocked to give thrombolysis, TPA, or actually sometimes reversal of patients who are having hemorrhagic strokes or on anticoagulation. Increasingly, we are seeing these all over here in Ohio and at University of Cincinnati. We're the fourth here in the state. But you can see they are popping up more and more and more. The Presto organization is kind of the organization of all these mobile stroke units that come together and share best practices and think about this. There's also a large clinical trial that's looking at the outcome through this organization as well. Some of the preliminary data that we have out of mobile stroke unit programs is that they do really well at improving time to treatment. Really traumatic time to improvements. You can see on the order of 30, 40 minutes, which is really fantastic. If you think about kind of how much time is really being saved. The first data on clinical outcomes was presented just 3 months ago, I guess now at this point, at the International Stroke Conference. It kind of piggybacked on some preliminary experience out of Cleveland to report the experience of what they're seeing in Berlin, which was one of the first mobile stroke unit programs. They compared almost 800 patients in each arm, and they actually saw a significant shift for clinical outcomes in that set. Now, this is still an abstract form. We're still looking to see kind of the full peer-reviewed study, but at least you put together kind of the operational metrics plus some of this preliminary clinical outcome, and it does suggest that these patients are benefiting. Now, a key limitation is when the mobile stroke unit is going out. And it really is truly accurate dispatch, because as you can see here from the kind of the more established programs, Berlin, Houston, Cleveland, they are going out often, but not often, at least based on how often they're getting toned out, to give TPA. Now, that's not a bad thing necessarily. You know, there's reversal of anticoagulation, there's advanced neurological evaluation, but if these are conceptualized as acute stroke ready hospital on wheels, which is a good and valid conceptualization, some of that accuracy of the dispatch is somewhat limited based on that. So this would be an example of a very sensitive system, right? So if they are giving TPA and they're evaluating far more than that, then they're flexible and understanding in terms of kind of basically overactivation. Ultimately, though, when we're in EMS, we care about right care at the right time, at the right place. And we have to think about what are really the best places for mobile stroke unit. We still don't know that, to be honest. I think a lot of it kind of depends, like I said, when it comes to these questions of EMS, really locally with the agencies, with their medical directors. Is it going to be that it's going to be in a city like Chicago where you have 14 stroke centers in the city limits and an additional 10 outside that the system can transport to? Maybe. Is it in a rural environment? Well, Alberta looked at this. They had covered a huge swath of Alberta. They had a kind of a rendezvous model, but they went out 68 times in a 1-year period. Is that the most efficient way? I don't know. I wonder if it's actually maybe something kind of geographically, kind of that sweet spot right in the middle, that not too hot, not too cold, maybe like a suburban kind of semi-rural area where there's a really decent transport time to the stroke center, where a mobile stroke unit with its diagnostics and therapeutics can maybe aid in the overall treatment course of the patients. A lot of considerations, though, when it comes to mobile stroke units. Not only is it ambulance, it's also radiation therapy, radiation certification. A lot goes into it. It's a costly upstart. Some of the reimbursement models are a little bit challenging, so it really is being conceptualized as a community resource, really, by the sponsoring agencies. It really does involve a lot of good education with partners, and we've done a lot of that here in Cincinnati. It's been we found very collaborative, really engaged providers here in Hamilton County in terms of wanting to learn more about the program and collaborating with us. And so our partners here have been fantastic. We think about, kind of where the best destination is once actually the mobile stroke unit goes there. A CT angiography is, boy, if you can think about what the best large vessel screen would be, is like, well, it would be a CT angiography. It would be the diagnostic study. Well, that's 100% specific. That's 100% sensitive, within the range of, the CT capabilities. But that is a really, in terms of thinking about what's the best destination, you get a ton of information from that CAT scan. But we do have to balance it against all the other considerations. One last thought before I leave you all is that, again, with COVID-19, look at this dip. This is kind of all the, basically a graph showing how often people are being evaluated for stroke in emergency departments and hospitals across the United States. People had been coming to hospitals. Word is getting out, hey, if you're having neurological symptoms, come. With COVID, we saw a huge drop. People are scared. They don't necessarily want to be at the epicenter of a COVID outbreak in an emergency department. So people, we think, are kind of not engaging us when they're having stroke symptoms. We're seeing a decrease in the number of strokes treated and evaluated across the board. So in your role in the community, be aware of this. It is still important for patients who are experiencing stroke symptoms to be evaluated in the emergency department. You are all wearing your PPE. We're wearing it in the emergency department. We want to create a safe environment for patients to get evaluated for their acute time-sensitive conditions. So as long as we're aligned in that message, I think that's really important, I think, for the public to be aware of. So hopefully you recognize that your role in EMS is critical to stroke care. Stroke, generally speaking, is treatable, but it is awfully time sensitive. And a lot of that really kind of is hinging on pre-hospital systems of care. And we look forward to these exciting pre-hospital innovations in the future, see if they work, see if they're really best for our patients. Thank you again. If we have time, I'll take questions. Otherwise, I'll take a look in the chat box. And thank you again for your time.
Thank you, Dr. Richards.